Well, first of all, thank you for the invitation. It's a wonderful opportunity to speak at this conference and also to learn from your experience with integrated care here in Ireland. And the session is called Evidence Base about integrated care, but I also try to translate it into practice, because if you don't translate it into practice, evidence is completely useful. So it will be a balance between evidence and practice. So what I want to do within the next 20 minutes, I want to discuss with you why do we focus on integrated care. Well, I think you're all familiar with that if you're looking at the current trends within healthcare. Second, what is integrated care? The concept is not very well understood, and you need to understand what we mean by it. So I will explain that. And last but not least, some guidance how you can achieve it in practice based on some previous work done in research, but also based on best practices we see across the globe. So, first of all, why integrated care? Why do we need to talk about integrated care at all? I think and we heard it this morning as well, I think this visualizes beautifully why we need integrated care. We face fragmented healthcare system, and especially in high-income countries, the healthcare system is fragmented. Everyone is treating patients in their own silo, and it's not connected. And especially for patients with a high and complex needs, like with chronic diseases or multiple chronic diseases, they face like several barriers within the system. And we see the barriers in terms of data, but also in terms of education of providers, and also in services. And the barrier here is between secondary and primary care, but there's also a barrier between healthcare and social care. And this makes that we also have adverse outcomes for these type of patients, which makes it really problematic. And one thing to consider here is that why we have created this fragmented system, one cause of it is called specialization. So we have highly trained professionals which are really specialized and focused on their expertise area, but integrated care is asking something completely different for them, and that's causing the problem we're facing across the globe now with our fragmented systems. And if you see the gap in terms of trends, what we're facing at is on the one hand, on the left-hand side, we have the supply of healthcare. And as said, there is a poor coordination of care, especially for the high-need, high-cost patients, which is caused by the lack of accountability across providers. So who is accountable for that particular patient's for a readmission on a Friday, and the next Monday does the GP knows what happened to that patient? Most of the cases it's not. And it's caused by misalignment of payment incentives. You see that a lot in countries because treating is incentivized financially wise, which makes it very difficult to integrate systems. And there's a lack of transparency in terms of cost and quality outcomes. It makes it very, very complex to show the efforts of your work and to know how we can improve it, because we don't have the data and it's not transparent. And last but not least, you see it on the bottom side of the slide, we know that's based on several studies that 25 up to 30% of harm caused to patients is caused by the bad communication across providers. So polypharmacy, readmissions, and so forth and so on can be are completely preventable by having a good communication across providers. And still we don't do it, and we see the bad adverse outcomes of it. And last but not least is the healthcare funds we spend in different countries, and the numbers, yeah, they are diverse, depends on the countries, but 30 up to 50% of the funds we spend in healthcare are pure waste because we don't use it efficiently. Well, if you know that this is on the supply side, how we do it, and you know the demand, and the demand that's coming, we have a huge challenge together to solve. Aging across the world, Japan is the beautiful example of the aging population, which is going to increase the upcoming years. But the most interesting, I find the most interesting, is multimorbidity. And we see in the OECD registration that 50% of the disease burden is already represented by people with 2 or more chronic diseases. So multimorbidity will become the standard within the upcoming years. And that means that our disease-specific standards and education programs we have are not useful anymore in the near future. And of course, the costs are increasing globally. This is what we spend globally on health and social care, and we see in every country an enormous increase in cost. So this is the gap we face and which we need to solve together. And if you summarize then the current literature, what you see by focusing on the solutions is that it's called the shift from a volume-oriented system towards a value-oriented system. And in essence, it means basically it's summarized by those 4 topics. In terms of payment schemes, we're moving from a fee-for-service kind of orientation towards a shared risk-reward, or some people call it value-based or population management payment kind of approach, where we incentivize and pay for the outcome you together achieve. The incentive is then not on treating a patient primarily, but also on prevention. So the prevention on preventing that someone get an adverse event or even get a chronic disease. And this is, of course, public health is very much embedded in this approach. And the focus, and this is quite interesting, is shifting from a focus on a patient, on someone with a disease, to a human being. So looking at a person within its social context. And why is this so important? Because we know for many, many years that focusing on that social context, the broader context of a patient, has a tremendous impact on outcomes. And that's the reason why this is changing. And last but not least is the information, where we used to be, and that's based on our statistics, on data sets. We can retrospectively look in the trends and what happens. We're now moving into a world of predictive medicine, so to say. We have algorithms which can predict an adverse event, so make it more proactive to build a change approach than we used to do in a reactive way. And this together visualize the change we see across the globe and also in the academic, and which you will also face here in Ireland the upcoming years. And if you talk about value, and I think this is critical to know, we have like 2 approaches which are very often cited in the literature. First of all, on the left-hand side, we talk about value-based healthcare, and that's the work of Michael Porter. And he came out with a book like this. I don't know if you have ever read it, but I would recommend to read it, because he comes up with an implementation strategy, basically how to create value. And he says health outcomes divided by cost is patient value. Very simple. I can make it more simple than that. But if you really start looking in that theory, he basically advocates a disease-specific approach. He said your implementation strategy is disease management. Nothing wrong with disease management, but the only thing is if you look into disease management, the improvement method is very linear. And what do I mean by linear? We have an intervention, and it directly leads to a better outcome for that patient. And we all know, everyone who works in healthcare, that is not the case. Healthcare is by definition complex, and a linear improvement approach will never work for a complex patient. And the third item he points out, it's a competition-based model. So competition based on outcomes or competition based on value. So the best may win and will be better incentivized. And that means that we create winners and losers within our system, and I'm convinced that if you want to improve the outcome of a community or a population, it's impossible to do it by competition, and you need collaboration. It's an all other perspective. And that's also visualized by the work of Donald Burke, triple aim. We heard it this morning already. What is triple aim? And that's more embedded in primary care or public health approach, basically. And if you look in the focus there, it's of course the population focus, that's one of the aims, but also there is the person-focused approach, looking at the needs of a person in a broader context. And I think based on the evidence we have of primary care, public health, I think much more value is created in a person-focused approach. The improvement method is like a circular or complex adaptive system theory is behind it. And we don't know exactly if we put in an intervention of a pilot if it directly leads to a better outcome. And why don't we know that? Because our statistics, models are not yet that good to modify that complexity. But we all know that if we think about healthcare, how health is created, I think more value is embedded in this concept. And also, how do you achieve the triple aim? If you look at the work of Barrick, very, very good. You see he approaches a collaboration approach, so collaboration across multiple stakeholders. Well, and if we heard the discussion this morning, about collaboration across different stakeholders, then we basically talk about integrated care. The main thing to remember regarding this slide is if you have an integrated care approach, please be very specific in what kind of approach you use. Is it value-based healthcare or is it the triple aim? Because they are completely different. Within a hospital, and quality improvement approach can be value-based healthcare, nothing wrong with that. But if you really want to improve the health of a community across stakeholders, you need to find your solution more in triple aim. So please remember that. So if we then gonna talk about integrated care is like the improvement approach to achieve your triple aim goals. And there is a brilliant paper, I can read it almost every day, I really like it. It's the work of Kuttner of 2009, Dennis Kuttner. And if you haven't read it yet, start at it this weekend, because this summarizes perfectly what integrated care is and what integrated care isn't. Because if we talk about integrated care, and this morning, again, we saw it during the presentation, everyone has his own perspective of how we see this elephant. And we only see one piece of the elephant if we talk about integrated care. And he also, and Dennis Kuttner pointed that out, but integrated care as a concept is an imprecise hodgepodge, meaning are as diverse as the numerous actors involved. So the definition on integrated care depends on your stakeholders' perspective. And what he also pointed out in this article is that integrated care is a mean to a certain end, and that end is obviously the triple aim, as I just explained to you. So integration itself should be never the goal or the end goal of your approach. And although we say it, I have seen a lot of projects across the world where this is the case. So then I ask, okay, what is your outcome? What did you achieve? And I don't get any answers. So this is making the evidence base of integrated care actually quite weak. So this is where I started in 2009. I read this article and think, okay, and what he pointed out is that we need a model. We need a solid model and a solid definition so we are able to understand integrated care, to measure it, and then we can improve it. So we came up with a definition where we try to link value to integrated care. You can read the definition on the slide. It's about, I will read it for you, value-based integrated care can be defined as patient achieves outcomes and experience of care in combination with the amount of money spent, triple aim, by providing accessible, comprehensive, and coordinated services to a targeted population. The group of care providers is collectively accountable and willing to take the risk for the quality and cost of care. And I think the last sentence is most essential. It's about taking risk and collective accountability, otherwise it won't work. And the key characteristics of this embedded in these definitions are person-focused approach, intersectoral collaboration, doing business together and taking risks together, because if you want to achieve a better outcome, you have to be at risk in some point and realizing change and results or outcomes. So this is a bit the definition, how you can achieve a better outcome and how you need to integrate across the different sectors. And this is derived from the rainbow model, which we saw already this morning, which describes basically the building blocks or components, domains of integrated care. And I will briefly summarize what it says, is that on the micro level, where we have an individual patient, there is an interaction between a patient or a citizen, whatever, and a care provider. And that's what we call something like service integration or clinical integration. And in terms of intervention, we talk about self-management, patient empowerment. These are examples of intervention at the micro level in the service. And we talk about service integration. On top of that, we talk about the Meso level. And there we don't talk about one individual patient, but we talk about the population or subpopulation. So more patients which are included in our cohort, so to say. And there you have different providers who need to collaborate to tailor the care for that particular population. That's what we call professional integration. But on top of that, you have also all the professionals are embedded in organizations, and that we call organizational integration, where the organizations start to collaborate together to tailor an intervention. And disease management is an example of organizational integration. And last but not least, we have talked about system integration. So it's the whole system approach, the policy approach, the payment schemes we put in place to enable the different forms of integration we have at these levels. And the assumption is that the more integration we have at those levels, you are able to achieve the triple aim. And that's an assumption, but we're still building the evidence to prove this. This is from the evidence point of view. From a practical point of view, you should remember this, is that functional integration and normative integration, those are the critical enablers to drive change in practice. What do I mean by functional integration is incentivizing collaboration across providers with different payment schemes, for example. Integration across different electronic health records is also an example of functional integration. And on the right-hand side, the normative integration is, do we have the shared vision on our outcome? Do we have a mutual gains approach in place that we align the different stakeholders together? And this is more so-called the soft-hand side of integration, which enable the different forms, and we are enabling to achieve the triple aim. So this is basically summarize the rainbow model. And what we did is we tried, okay, we had the model, we had a definition, that was nice, but then as an academic, I want to measure, because if I don't measure things, I don't believe it. So we started with validating and developing a patient-reported experience measure, a PREM it's called, patient-reported experience measure for integrated care. And we also validated one for care providers, but for now I will focus on the PREM for patients. So we took the rainbow model, we started developing a questionnaire surveys, and we started to validate. And here you see on the left-hand side which dimensions are included within the patient-reported experience measure. It's like 4 domains, 24 questions, takes on average 9 minutes to complete, and the psychometric properties are great. The paper will be submitted later this month, and this is my work of like 6 years, so I was really happy when I ran the factor analysis and I found the dimensions back, but that's crazy stuff of an academic, I would say. But at least we were able to measure, and also for the care providers. So we have been able to measure this in 23 countries already. And here you see where we try to measure integration from the perspective of the patient, or through the eyes of the patient, because by the end of the day, the patient is the only one who can tell you how fragmented your system is, because he or she will experience it, so they can tell you. I don't believe a care provider, because he will always be more positive about the results, and that's also what we find in these studies. So what we find out, and here you see a sample of 90 countries where we, based on the PREM score, so based on the scores of a sample of more than 50,000 chronic disease patients. And here you see the 90 countries plotted across the average surface coordination score, so it's the first bow of the rainbow model, so to say, and the overall integration score. So we are able to build an index on all the different scores. And what we find out is that the UK, which I think was always one of the leading examples of how integration, because they publish a lot of papers about it, I think. But if we ask the patients, they're actually telling us we have a disconnected care experience. If we look at Germany, this one I expected, because I think I know Germany quite well. The patient indeed point out it's a fragmented or disconnected care experience. Australia, also investing a lot of money, time and efforts in integration care, and still patients say it's a fragmented care experience. And interestingly, we have only like 6 countries, and because of the study needs to be published, I can't show you all of the results, but I will once it has been published. The countries here, I can tell you, are not the usual suspects if we talk about integration. It's not the UK, that you know, not the US, but it's more the lower economy countries, and there's some high economy countries behind it. And that's really interesting in terms of learning from other countries where to look at. Because the usual suspects, if we ask the patients, they basically tell us it's not integrated. So please keep that in mind when you start doing your own approach. Measure this first, otherwise you don't know what you're doing. So, how can we realize it based on the evidence? First of all, I want to show you some best practices, the usual suspects in examples of integrated care. And I'm from the Netherlands, I'm told, so let's see what happens here. First of all, I think you're all familiar with Blue Cross Blue Shield initiative. It's an alternative quality contract. It's, well, nice example, you can look it up. It's in the United States. And what they did in their approach, they integrated primary and secondary care, so primary and hospital care. And they put in place a 5-year shared risk, shared savings contract, also with a fee-for-service contract. And if you look at the results and you can look it up in the articles of Sung, you see that they had a reduction in cost, significant reduction in cost compared to the benchmark group, and also a significant increase in quality in their quality indicators. So what is telling this us? We need to have the functional enablers in place, integrate between primary and secondary care, and we are able to improve outcomes to create value. Basically, that's what it's saying. And then everyone says, yeah, we don't like the United States because it's the worst example of a healthcare system. I agree. So we're going to look at the UK. And you're more familiar with this example than I am. It's Torbay Devon, the community care groups, and there they have also run evaluations. And what they did, they had a multi-year health bucket, Health and Social Service Act. And again, we see compared to the benchmark group, they had a significant reduction in cost in terms of bed days, that's how they calculated, and also an increase in quality indicators. So again, telling us that in an NHS system, which is completely different than the US, by integrating across social primary and secondary care, we are able to improve our outcomes, which is great. Also in Germany, gesunde Kindertaal, I think you're also familiar with that example. They implemented a disease management approach. What they did was an integration between primary and secondary care. So medical specialists and GPs were together in one organization, so to say. Also a 10-year contract, which is fundamental, and a shared savings agreement. And if we compare that, the results of that study also compared to benchmark group, a significant reduction in cost and quality improvement. And now what? Let's have a look at the Netherlands, where I'm coming from. Basically, we did everything right, but we forgot one thing. We had a disease management approach, which is completely the same as they did in Germany. But they forgot one thing. They had a bundled payment, which was really nice. And bundled payment, effective bundled have been, you can look up the papers. But they forgot to integrate secondary care or the medical specialist. It was a political choice at that point in time, in 2006. And if we look at the evaluations, we see a slightly increase of cost for the diabetes patients, and we see almost no improvement in quality indicators. And the recent evaluations, which are not yet published, telling us that for the other groups, like cardiovascular risk management and also COPD, it leads to an increase in terms of cost. And that's interesting, because we made a mistake by design here. And now we don't achieving our outcomes, and we're discussing how should we do it, should it be hospital-based, blah, 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 but we're not having the discussion on the table, how can we integrate across the different organizations between primary and secondary care, which is, I think, which is this pointing out, fundamental in achieving your outcomes. And the previous study I showed you in measuring the patient-reported experience measure, we now found an effect of the more the patient says the care triagram is integrated, it correlates with their clinical outcome, a die-hard clinical outcome in mortality, eGFR, blood pressure, and so forth and so on. So this gives us the first pieces of evidence that integration across the continuum leads to better outcomes. So what are the showstoppers or the barriers within the Netherlands if you look at it from a broader perspective? First of all, organizational integration. That's where all fun happens at the moment, or not, so to say. Here, people don't want to give up their organizational autonomy, so to say, their business case. They don't want to give up their business case. And on the other problem we face in the Netherlands is we have a lack of functional enablers in place. We have the payment schemes, but we don't include the medical specialist, and we're completely unable to make interoperable electronic health records. Everyone has his own health record within his own silo. And here we see, I think the Netherlands in this regard is a beautiful example that the IT data management will be the fragmenter of the near future of our healthcare system. So please keep this in mind if you start designing it here in Ireland. Don't make the same mistakes we did. So is there any positive news? Yes, of course, there's always positive news here. How can we drive change then, based on the evidence we have, and which I think is fundamental? First of all, follow the patient using the 4P principle. Personalized, preventive, predictive, and participatory. Measure your patient journey is here the key message. Measure it and follow your patients. Second, on the professional level, use predictive tools. Use predictive algorithms to predict the adverse events of a particular population. So you can advancing in your planning and organization and your intervention. Third, create inter-organizational networks and realize also a legal form around it, which is fundamental to have something embedded within your system. Without inter-organizational networks, it won't happen. And last but not least, it depends a bit on in which country you're located. Value-based payment methods are also critical to drive change. Other payment schemes with incentives and somehow prevention or better outcomes. But it's the last step, and it's not. And everyone is talking always about finance and money, but it starts here by looking what is the need of your patient, and then start addressing, and then adjust your payment schemes. To summarize, how can we move from theory to practice from integrated care? On a micro level, measure your disconnected patient journey and do it evidence-based. Use evidence-based tools, otherwise you don't know what you're measuring. Second, at the Meso level, implement also evidence-based interventions and not practice-based. I've seen a lot of projects the last years, and I always see that people start designing their own intervention and then don't look up in a Cochrane systematic review what intervention already has been proven in terms of effectiveness and better clinical outcome. Use that information because there comes tons of information every day around, and use that information. Don't start to reinvent the wheel yourself. And second, make an integrated business case to address the barriers at the organizational level. And an integrated care business case means that you start predicting the effects in quality and cost across the different stakeholders or the different organizations within your network. If you make the business case for your own, it's fine, but you're not going to be successful. And this is a very powerful approach of really aligning the different interests of the stakeholders and to solve the barriers in terms of financing, data management, and collaboration, which are the key showstoppers I showed you for us in the Netherlands. And last but not least, at the policy level, work further on transparency in triple aim outcomes. Not only the clinical outcomes, no, it's more fun to work on the complex outcomes in terms of triple aim. And I think what you have done here in Ireland, you made already tremendous increased steps towards to make this transparent, which is really, really great. Before I close this presentation, I have 4 questions for you, and I'm an academic, so I want to measure things. So I want to ask you to answer these 4 questions by raising your hands if you say yes. So first of all, we measure the disconnected patient journey. Who says yes to it using a validated tool? Who does it? Higher, please, otherwise I can't see it. Okay, first step, you can start with this on Monday. Second, we are willing to become financially accountable for the triple aim outcomes at a community level. So this means you get the financial risk, not at a government level, but at your organization level. Who is willing to do that? Please raise your hands. That's better. Great. Third, we use predictive risk stratification tools in practice by using your data and start predicting the adverse outcomes. Who uses those tools in practice? Fantastic. Great. And fourth, last, we have access to all quality and cost data of each member of the community. Raise your hand, please. Okay, lots of work still to do. I want to thank you for your attention, for your honest voting, and I wish you have a wonderful conference and start bringing this to practice. And I hope within 3 years I want to see a tremendous experience from you in Ireland as well. Thank you very much.